So good afternoon, everyone. By my watch on my iPhone, it looks like it's exactly 5 o'clock. So I'd like to call this meeting to order, which is deemed a special meeting of the Board of Health of Knox County at 5 p.m. on 11/20/2020. And even though we're not having a vote, I suppose we should have a roll call. It's not in the agenda, but let's go ahead and have a roll call by voice. So Narda, if you're online, if you could send us through a roll call quickly. Thank you.
So Narda's not here this evening. Charity Menifee will take the roll.
Okay, thank you. Thank you, Dr. Buchanan.
Dr. Drake.
Here. Did you hear me?
Shoot, they can't hear you. I'm muted. Sorry. Sorry.
Dr. Hurt.
Here.
Dr. Gacher.
Here.
Mayor Jacobs.
Here.
Dr. O'Brien.
Here.
Oh, great. Ms. Roma.
Here.
Dr. Shamia.
Here.
Dr. Souza.
Here.
Ms. Wagner.
Present.
And Dr. Buchanan.
Here.
All present.
Thank you very much. So in this meeting, this is, I would envision primarily an informational and discussion meeting. And so the first order of business is going to be a kind of a local situation report or update from Knox County Health Department by Dr. Buchanan. So Dr. Buchanan, if you will lead us in that discussion, please.
Sure. Today we only had 92 confirmed cases since yesterday's report, giving us a total of 16,480 confirmed cases since March. We have 912 probable cases. 15,228 of our cases are considered inactive, giving us 2,018 active cases. 540 individuals have been hospitalized during some portion of their illness. 86 Knox County residents are currently hospitalized. And sadly, we actually had 6 additional deaths to report today, raising our total to 146. That is not our highest daily total, but close. We've had 2, this week I think we had a day with 7 deaths to report, and today 6. Looking at our benchmarks, on the first benchmark, sustained reduction or stability in new cases, we continue to represent this benchmark as a red light, as we've had several red flags and hit new record high case volume in this week, with some days where we had over 300 new cases. Our second benchmark, community-wide sustained and increased diagnostic testing with consistent or decreased test result report turnaround time. Regarding testing, we did have some red flags and some yellow flags. They were on consecutive days during this time period. However, the total number of tests conducted has gone up. But if we add into that the turnaround time, which has decreased significantly, it's now between 4 and 5 days. And actually, for us here at Knox County, it's more closer to 7 days, I believe, in turnaround time. I don't know what the hospitals are experiencing. Because of those factors, we're representing this benchmark as red as well. Our third benchmark, sustained or increased public health capability. We did make some tweaks to this benchmark, given our increased use of Tennessee Department of Health staff to help with some case investigations and contact tracing. But even with adding that and making that change with our increased caseload, we represent this yellow. We continue to maintain our goal of reaching out to cases within 24 hours and contacts within 48 hours, but with the rising case numbers, that's just logistically not possible for us to do. We're one of the few health departments that were not giving cases straight to the Department of Health. There are a few other health departments that aren't doing that at this time, but we made that decision last week that we would need to do that. On our fourth benchmark, healthcare system capabilities remain within current and forecasted surge capacity. During this time frame, there were 9 consecutive red flags detected for inpatients with COVID, 11 red flags for ICU beds for patients with COVID, and 2 red flags and 1 yellow on consecutive days for ventilator patients with COVID. After speaking with the hospitals, we will represent this as, to get this right, yellow worsening, as is indicated by the yellow light with the number going, with the arrow up indicating that things are getting worse, or yellow worsening or rising. Fifth benchmark, sustained or decreased COVID-19 related death rate for identified positive or probable cases. Unfortunately, we've seen 10 deaths related to COVID over the past 7 days and 26 deaths in the last 14 days. With that information, we represent this benchmark as red.
Dr. Buchanan, can I jump in?
Yes.
All the data that we're reporting right now, this is Charity Menifee, is the data from Wednesday's benchmarks.
Yeah.
So just want to make that clear. That's not including what she's talking about with
Oh,
flags
the 7.
and the deaths and that. That's
Right.
not from today's data.
Thanks for that clarification, Charity. We only update the benchmarks on Wednesday, so we did not update the benchmarks again. Looking at our supplemental data, as of Wednesday, our 14-day trend line shows 39 new cases per 100,000, and our 7-day trend line shows 45 cases per 100,000. And then on the chart below, you can see the 7-day average percent positives in Knox County as of Wednesday was 13.49%, which is a slight increase from last week. So I just, little editorializing, not really editorializing, but just statement of fact. These are the worst numbers we've seen. And I believe Dr. Hurt might say more to why she asked for this meeting, clarify that, but these are the worst numbers we've seen, and they're not trending in the direction we'd like to see them, especially the hospitalizations and deaths. The lower number of cases today, we believe, is due to a problem with the state reporting system that has not been working properly for the past 24 hours. So we anticipate a large number of cases, new cases over the weekend. So I don't know, Dr. Hurt, if you want to say any more about why you asked for us to have this meeting.
Sure. To me, it's just the obvious. I mean, our local numbers are getting so serious as we feared. That, you know, I believe it warrants our community's vigilance and us exploring other measures to save lives, to protect people's health, to protect our healthcare system, keep it intact and running. And I really believe that waiting until next week, literally the eve of Thanksgiving, would be too late for us to begin discussing what our options are to keep our community safe.
Thanks. Dr. Gocher, I believe Dr. Shamia has some hospital data, if you would like to hear from him as well regarding the local situation.
Sure. Dr. Shamia, if you have a presentation, we'd love to hear it now.
I mean, yes, I have if I can share my, because I just sent it as a PDF, so we can either run that PDF or I can attempt to, but it's just a brief version of my usual presentation. Okay, great.
There you go.
Super. So if we can scroll to the next slide. So, and it looks like I've got to move my, there we go. So you see just the pace of cases. This isn't different than what Dr. Buchanan showed. It's a different visual way that we're used to looking at it. But you see just how significant the week ending November 15th was because of the timing of our meeting. This is the most recent that we had at our fingertips. This is, you see the pace that we're on for November for the month, both in the county and the district, with still quite a bit of November left. Next slide, please. So this continues. You see the age demographics, and even more so in that 51 and over age distribution. I can share with you, I don't have a slide, but we did a snapshot of a single day of all the patients that we had in our hospital and their ages. So in the intensive care unit, we had 4 patients over 70, 7 between 60 and 69, 5 between 50 and 59, and 1 between 40 and 49. And then in acute care, not in the ICU, we had 28 over the age of 70, 9 between 60 and 69, 12 between 50 and 59, 3 between 40 and 49, 4 between 30 and 39, and then 1 less than 30. So you see that while there's definitely more, this slide just talks about who's being diagnosed in that the group 51 and older, but the age distribution of those hospitalized, while it certainly slants and more so 60 and above, we're definitely seeing patients in their 50s and 40s being hospitalized. Next slide, please. So this no news here. This is a statewide issue. I think that's all we'll say there. Next slide, please. Our positivity rate, this is another way to depict it, but we're at any person's level, and we've been there for over 30 days of well over 10%. And again, the significance of this is that the effectiveness of even a really well executed contact tracing process, it's not that as effective to control things when you're getting this type of positivity rate. And what that also means to me is that we're much more likely now than ever before just to casually be around somebody who has COVID-19, who either isn't going to become symptomatic or they're pre-symptomatic, but they have the potential to transmit that to us. Next slide, please. So hospitalizations, just the ongoing pace of this. We did a length of stay analysis again on that same day, or actually no, we did it for several months. Generally, we're having people with COVID-19 stay between 6 and 7 days, but we have this subset of outliers who stay over 14 days in the hospital. Next slide, please. So this is just the same representation of the inpatient census each day across those counties. And so you can see that we're just at this consistent rate of rise. After that, we had that plateau around the 236. And recall, last time we plateaued, we went back down and then we spiked. But this time we just leveled off. We didn't really go down, and then we spiked. And that spike really happened. We all felt that. It happened fairly quickly. Next slide, please. And then I always say, take this for what it's worth. This builds heavily on the most recent trajectory of the data. So we've not seen this be precisely accurate, but certainly the trajectory from the last few weeks is showing that this is worse. One final comment I would say is that there's a little bit of a disconnect. Actually, you can bring down the presentation if that's all right. If you look on the benchmarks page, it talks about hospital capacity and licensed beds, and that is if I understand it correctly, that's every bed, including all the beds at Children's, and I'm not knowing whether all those beds are consistently staffed. I can say that on that daily capacity call that we have, where we essentially compare our COVID situation and our overall bed situation with all the health systems, we were already full the vast majority of the time, and so on our most recent call, the number of beds that we're working with is not that number that's projected on that benchmark slide. And so we may need to true those up, but that suggests that there's 25% capacity in the community in beds. That is absolutely not what we're feeling. And given point where we are. The other thing that we've always said is that it's not just about the number of COVID-19 patients. It's a complex interaction between the patients who are hospitalized with COVID-19, other patients who are in the hospital, and that waxes and wanes, and then the staff that we have at any given time to staff beds. And so we've still been, the reason we're yellow but worsening is that we've still been able to manage through that, I think largely due to collaboration between us, without fundamentally impacting hospital operations and services that we deliver. But as you look around other communities, there is a point, there's only so high that number can go before some of those things do start to be affected. So Dr. Goetsch, I'd be happy to answer any questions.
Thank you. Any questions for Dr. Shamia?
Yes,
So-
this is Maria Hurt. Dr. Shamia, I want to be sure I understood the point you made actually at our last meeting in comparing capacity right now, census, to our highest ever local census during the worst flu season. I'm asking you to pull that kind of off the top of your head, but my understanding was where we are now, census and capacity wise, is worse than our worst flu season census. Did I get that right? You're muted.
Yeah, that's absolutely correct. That.
And we're not at the height of flu season.
Right. Yeah, that's right.
Or COVID season. Although I hope I'm wrong. Thank you. Dr. Goetsch, you're muted.
Other comments or discussion of either Dr. Buchanan or Dr. Shamia's report?
Can I ask
Go ahead. Go ahead.
Thank you. For Dr. Shamia, so then regarding COVID patients right now, I'm wondering, is there enough equipment available to care for these patients? Is there enough medicine available? Are there enough ventilators available? Where do we stand with that? Is that a valid question?
Yeah,
Even?
no, it's absolutely a valid question. At this point, we don't, we're not sensing an issue with equipment. So ventilator wise, for example, we're fine. Some of these patients require the way you keep them off the ventilator is you've probably seen pictures, there's this nasal oxygen device that's very large that goes underneath the nose, and so it requires a blender, and there are components to that, and we've tried to increase our supply of that. Medications, certainly the one that gets the most attention has been remdesivir, and thankfully that supply chain opened up nicely, and so we feel like the hospitals feel comfortable with their supply of inpatient remdesivir. There'll be other things coming down the pike, and these things are generally under emergency use authorization, and so usually when these things start, we don't get much, but that's more of something on the front end of care, and so we wouldn't expect to have a ton of supply of something that's brand new, but in terms of that bread and butter stuff, supply wise, we feel okay.
Dr. Shamia, I have a question sort of as a follow-up to that. How common is it to be using convalescent plasma on either acute care or ICU patients? And I'd heard that Medic was out of convalescent plasma.
No. Yeah, Dr. Goetsch, thank you. My brain didn't go there, but it should have. And so we have had an issue this week intermittently with convalescent plasma. So the idea of convalescent plasma is it's basically someone who's had COVID and has antibodies donates plasma. And then by giving that plasma to another patient who is sick and they meet certain criteria, then they hopefully benefit from those antibodies. And we have intermittently had issues with the supply, but that reached more of a significant issue this past week. And I think they worked through it the best that they could. But one of the messages from this evening would be that if someone has had COVID, then they presumably have antibodies. And if they are able to donate plasma through Medic, and I think you can go to the Medic website, and then that's by appointment, as I understand it, because donating plasma is a little different than donating blood, that would be very, very helpful. And we have had, while we're okay on remdesivir, and certainly the other thing you hear about is dexamethasone, we're okay on that. Plasma had become more of an issue this week. And thank you for Dr. Gocher for bringing that up.
You're welcome. Any other points for discussion? I guess in maybe another follow-up question, Dr. Shamiya, you know, it seems to me that the sort of the critical link in the system is the intensive care unit patients. We know that not every ill hospitalized patient is going to be in the units, but there will be. How close are we to capacity problems, either with staffing, equipment, or bed space throughout the community and the units?
So, so equipment-wise, that's not really something that we've talked about as being an issue. I think staffing-wise, everybody. I mean, this has affected everyone's work situation, but we certainly have people out because of COVID, or because they're pending in the process of being tested, and so that causes daily staffing challenges. That's not unique to the intensive care unit. The length of stay in the intensive care unit is longer. I know everybody's head kind of tends to go in the more catastrophic sense to the intensive care unit, but you also have to understand in modern medicine, we house some pretty sick patients in the non-intensive care. So you can be on quite a bit of oxygen, but if you're not really worsening, then you don't necessarily need to be housed in intensive care. So I guess, Dr. Gocher, we're not overly focused on intensive care specifically, as opposed to just thinking about broadly how much, you know, the more COVID-19 patients we have, how it impacts hospital operations across the board. The other thing is anyone who spent considerable time in intensive care will then spend considerable time usually outside of intensive care. And so either way, there's a hospital bed that is occupied in that situation.
And Dr. Shamiya, if I may have another question, is there, within the hospital collaborative, is there a discussion or movement towards either not having elective cases either be strictly ambulatory surgery, or slowing down or canceling the number of elective cases in surgery?
So I mean, naturally those conversations occur. The community is doing its best to align and collaborate so that if I mean, you know, this is complex, so it's probably never going to be completely precise, but if that happens, as much as possible, the community does that together. Certainly, I'll say this, as we think through our next steps in our surge plans, and we've had a surge unit intermittently open, including we had it open, I think, 2.5 days or so this week. To be able to open those, you need to have staff to do that. And that's in the context of already having some staff that you would normally rely on who are potentially out with COVID-19. And so one of the ways you can do that is you reduce, you know, by reducing certain things, you hope to acquire hospital beds by doing that. But in a perfect world, you'd also acquire some trained staff to do that. And so, I mean, we always have to be 2 or 3 steps ahead because of just looking at the trajectory of things. And so I think each system is having those conversations. But, you know, our goal is to prevent that from happening, because there's you know, it's non-essential there's these words that get thrown around. There's elective, there's non-essential. But what we without question learned last time is that, there are some things that may not be emergency, that the more they are delayed, the more something goes from being purely elective to actually it's now caused more of a health issue, and the person's had a detrimental effect because of the delay. And so we have a commitment to delay that as much as we can, but it's happened in other places.
Thank you. Other questions, comments from the board members?
Dr. Gocher?
Yes.
Just kind of in the full scope of the local picture, UT's not on, University of Tennessee is not on, but we did look at their data. Their numbers are kind of level. Lisa, I don't know if you want to talk to cases in the schools. Are they reflecting what's going on in the community and rising?
Yes, they are. I mean, the cases have risen significantly within the schools, and we've had several schools to go red because of that. So what's going on in the community has impacted our schools quite significantly.
Other comments at all?
I have a question for Lisa. Have they thought about having all virtual again and no in-school participation?
They monitor the data daily with the local health, with Dr. B and everybody at the health department, and they monitor it every day. So we'll continue to, schools will be closed based on the reopening plan, the metrics for our reopening plan. So that's what we'll use. So right now.
Thank you.
Okay.
Any other discussion on our local situation?
Dr. Gocher, at some point I sent out the Nature article to everybody in the group, and I would like to be able to show the board and the public kind of a local situation. I was able to actually pull the mobility data for Knox County for this past week, and just to kind of give all of us a flavor of where people are going. So just let me know if it's now, or I didn't know if Dr. Buchanan had anything she wanted to present at this point.
Well, I think in the agenda item of local situation update, local situation mobility would be very appropriate if you want to go ahead with that.
Okay, I'm going to try. I don't know if this is going to work. I may have to have help from there. It's just 3 slides. Let me see if I can do it. Hold on. I don't know if it's going to work. I'm having issues with my computer. I'm so sorry.
We've got it. We can do it.
Go ahead. Yeah, if you could do it, I'm having issues. Okay. There we go. This article that I sent to all of you, this is just a slide kind of giving the abstract. This was talked about a lot in the health news this past week. And what it did was it looked at aggregated mobility data that was able to be called from the 10, I guess, largest metropolitan areas early in the pandemic up through the end of May. And what the model did was it basically said, and it's kind of highlighted this in the middle, our model predicts that a small minority of super spreader points of interest account for a large majority of infections, and that restricting maximum occupancy at each of these places is more effective than uniformly reducing mobility. So go to the next slide, please. So here it is based on the 10 large metro areas in the United States where they found that by modeling early in the pandemic where people were going to, and this is based on aggregated cell phone data that literally can locate and tell how many people went into X restaurant or X grocery store. So the number one area that, and they use this term about most effective establishments to close to reduce infections. It doesn't necessarily mean that, but this is where the most concern is based on modeling, that full service restaurants were number one on their list. Fitness centers, cafes and snack bars, coffee shops, etc., hotels and motels, limited services restaurants, and religious organizations. Now, one thing I'm going to say, no matter what our discussions are today, we are not affecting or proposing any regulations that would affect religious organizations. That is not in our purview. And so I want to kind of get that off the table. I also want to state that in looking at what we have locally, the data we have, which is from the same company, SafeGraph, they share that with us locally, and I have that data for our area. Go ahead to the last slide. This is the data set for this past week, and I just have a redacted piece of this over on the side. And what we did was we pulled and looked at what they call points of interest. So this could be restaurants, motels, schools, churches, whatever. And we put in there looking for 100 plus individual visitors during the week and staying there at least 15 minutes. When we did that and ran it through the system, it came out with 639 places in Knox County this past week that met those criteria. A lot of restaurants, a lot of fitness places. What's interesting, and this is kind of good, very few hotels or motels are on the list. There's a few, some bars, not a huge number. This is just, again, this past week. A lot of people going to schools, that's kind of expected. A lot of people going to, churches, synagogues, et cetera, kind of expected, again, during a 1 week period. And you look for a number. So if you look at over to the side on the right side, if you take the very top line, which is a little tough to see at this one location, it says that people on average stayed there 49 minutes. There were 129 people, visit counts, and then it says visitor counts. And I think that basically comes down to individual cell phones versus maybe going in and out. So somebody with the same cell phone may have gone in there additional times. So you look down that list and there's all sorts of, visit numbers. There's one down there that's 1,721 visits for an average of 25 minutes. So I have the actual data sheet for all 639 establishments. This is really, for the long, for the kind of 30 minute to an hour time period, a lot of restaurants, a lot of fitness facilities, and some of the bars. We will not have an issue with schools after Thanksgiving. That number is going to really go down. We don't control religious establishments. We can only strongly encourage all churches, synagogues, et cetera, temples to please, follow the 5 core actions. But I wanted people to know that we have this ability to get this data set and that we can look at this, and that based on the study, if you want to make good choices based on the 10 metro areas around the country, that where people move in and out of the most, being honest, are restaurants. And that's one of the biggest areas. And then fitness facilities are very high on that list also for us here and nationwide. So if we have to talk about additional mitigation efforts, this may help guide us on which way we want to go. So I just wanted people to know that we had this and it is available to us. And that's it for now. Any questions?
Dr. O'Brien?
Yes.
Is there any way, and actually there is, but I don't know if they have the data, of tracking proximity of cell phones to one another? Back in the spring when the stay-at-home order was issued, the UT did a presentation for myself, Mayor Buchanan, and I think Dr. Buchanan as well. And they were able to take a deep dive into the data, actually see how close cell phones were to each other for a period of time. And is there any way to do that? Does this company have that information?
I would have to check. I'm new to this. I read the article and contacted the company and found out we actually get the data set sent to people in Knox County. We have different individuals, academics who have the ability to get this. And that's what I did. I called a friend who, and by chance asked, do you know how to get hold of this? Oh, I'm on this list. I get this already. So I could ask them and see if that's something that could be done. This kind of mimics what, the governor used. He used a different company's data back in the spring. This is the one that this study used. And this one, having looked at the spreadsheet for this week, is exceedingly, it tells me exactly how many people went to Walmart or to, what shopping center. So they'll tell the whole shopping center, then they'll tell individual establishments. So we can look at how people are moving around the community, and we can compare it with historical data to see if that's dropped or stayed the same over time. Unfortunately, we're still pretty mobile in East Tennessee. And so because of that mobility, we have a greater chance of causing spread. So, yes, personal private gatherings are probably a very big piece. This does not look at homes. This does not look at individuals, private areas. This is looking at businesses and addresses that relate to businesses. And it's aggregate data. There's no way to know who that was or anything of that sort. So I want to just tell that to everybody. This is just people moving in and out. It'll count cell phone numbers basically, and then how many visits per number. So I can ask that and see if we can get that, if we need to use that for making some decisions.
So Dr. O'Brien, along those lines, you're probably familiar with it, but the University of Tennessee Medical Center has a Canary report.
Yes.
And the Canary report has mobility data based on counties and based on day of the week. And you can see the amount of movement in terms of miles per day that people make as they commute or as they shop. It's very, very aggregate because it just talks about counties and amount of movement per day, but it's part of that puzzle.
Yeah, I just checked. The person that's helping me just texted saying we can get that data about proximity, that there are some other companies that do provide that sort of information. There are programs that tell you've been close to somebody maybe with COVID once they've been identified. That's been done in other countries. I don't know if that's done much in the United States, but we could look and see how people are moving a little bit more specifically across the community. But as I say, business-wise right now, tops on the list for us pretty much are going to be the restaurants and the fitness areas. That's our two bigger ones right now for the last week. Again, this is just for the last week.
So Dr. O'Brien, the cell phone to cell phone contact tracing algorithms were, I believe, used in South Korea for the last several months. There's probably, personal privacy issues that prevent it from being done in the United States, but it is one of those systems which was used with, I think, some efficacy in South Korea.
I think so. They've really had, under 1,000 total deaths in South Korea, if I remember correctly from data early this week, and with what we have. So they have really ratcheted down, but they did a comprehensive, countrywide systematic way of dealing with COVID.
Thanks for that discussion. Anything else that we need to go over with the local situation? Hospitals, out in the local environment, health department issues that are specific, that are uptakes now. Any other discussion that we need to have about the local situation?
Dr. Gocher, I had one additional topic, and I think it's not just local here, but it's pertinent to everyone, and that is just the vaccine news that we've received. And I wanted to go into that in just a little bit more detail. So I think most people are probably watching, but the Pfizer vaccine with about I think 94-95% effectiveness, the Moderna vaccine with the same effectiveness. These are both 2-dose vaccines. So it'll be between 21 to 28 days after the first dose, you get the second dose. These are not the only vaccines in the pipeline, and the speed at which these were developed and then the effectiveness that's been described is really, really stunning. And so knowing full well that not everyone may choose to take the vaccine, and also we really do not know when the vaccine is going to be available to the general public. But I do want to say that, that is on the horizon. And, from our standpoint on the hospitals, we've seen that as the best news that could have possibly come down the pike, not just because it was announced that they're approved, but the level of effectiveness and the fact that they may generate some level of longer term immunity, which is really, really positive news. I think the thing to realize, though, from the standpoint of what we're going to be facing in November, December, January, and likely February, is there's a few factors to that. One factor is that first of all, the vaccine, there has to be enough distributed to be open to the general public. And then of course, there may be certain risk groups that go first. After the first dose of, at least for these two vaccines, after the first dose, a few weeks after that, you get some immunity, as I understand it. And then after the second dose, which is a booster dose, a few weeks after that is when you really felt, if you're going to be immune, and no vaccine's 100% effective, that's when you really have the immunity. And so, it's not like that. The way it works is once you get the vaccine, then you're good after that. I mean, this is all going to play out, and I think it's been well described that all these public health measures don't go away in the immediate short term. But the point of that is that this is really good, positive news. But the other point of that is for people to really, for the general population or any one individual to get that effect, it's going to take some time, but it's on the horizon. And so I just, as people are conducting themselves in their personal life, the closer we get to that vaccine, if something happens where somebody gets really sick, they get hospitalized, it in some ways it seems even more tragic in a way, just as they were that close to if it's somebody who chooses to take it. And again, I understand that not everybody is, but I say that to both be positive and to really, to me, it's incredibly encouraging. But I don't want people to have the misconception that we don't still have some things we've got to get through before we see the real benefit of that.
Dr. B, could you speak to that? I know that we're one of 4 states that is receiving the vaccine first, and as far as the distribution and how the state has prioritized and is going to run that program.
Yeah, so we are participating in pilot, but it doesn't actually mean we're going to receive vaccine any sooner than anyone else. I'm not clear on what the pilot is, to be honest with you. But we have been told by the Department of Health to anticipate receiving vaccine sometime in early December, maybe. I mean, that's, we've all been through enough flu seasons to know that I don't believe I have vaccine until I see it, because it's always in the mail. But we're excited about that. We're very excited about that. We anticipate receiving, the Knox County Health Department will receive our first shipment will be about 975 doses. We've already working with our first responder partners to get those folks vaccinated. The state has come up with a tiered program. There are tiers within the tiers. So tier 1A are first responders, folks who work in long-term care, and hospital employees. Those are the first tier folks. And then in tier 1B come outpatient providers and others. So we've already begun to develop those relationships. And my staff is excited, one, about doing something besides testing. And they're also just excited to be vaccinating, because they know that's something that's going to be positive for the community and be protective. Again, I want to remind everybody, vaccine will not be mandatory. Vaccine will be voluntary. The one other caveats with these vaccines is if you get brand A vaccine the first time, you have to get brand A vaccine the second time. They're not interchangeable. Some vaccines are, but these are not. And almost all of them are 2-dose vaccines. Right now, what I know are there are probably 4 other vaccines in the pipeline to be coming out after the first 2 that Dr. Shamia talked about. The first one is really a challenge to manage. It's the ultra cold one, and has a lot of logistical challenges. The second will be a whole lot easier because it's just frozen, which we're used to managing, and your regular doctor's offices are used to managing as well, which that part's encouraging to me, because what I really want to see is get it out into the doctor's offices where they can give it to their patients, because that's where it's going to really have the biggest impact on our community. So we'll be looking at how can we increase it out in the community, not just by us giving it but by also helping doctors' offices get access to it.
So I'll say, I mean, there is this light at the end of this tunnel, but we've got to navigate through this tough time before we really start to see the benefit of that.
So one other quick point of discussion, and that is for those who are so inclined and may feel that this would be helpful to the public at large in a larger way. We have phase 3 trials of the AstraZeneca vaccine that are ongoing right now at the Clinical Research Center, and I believe they're still enrolling folks for that. That it's somewhere in mid-phase 3, I think, and there may be others that will be online. You have a 50-50 chance of getting the vaccine. You may be vaccinated early. You may get saline, but it's in a way sort of a patriotic effort for people who are so inclined to step up. Any other discussion on our local situation? If not, we can go to the next topic, which is review of regulations in other jurisdictions or states, how other states are handling this nationwide surge.
So anybody else have anything to share about that? I'm happy to let you. But we did look at some various resources. AARP has a good resource on what other states are doing. Nobody has a really good resource on county to county comparisons. It's really, way down in the details to do. So we really have to rely on the statewide resources. Then also New York Times, their COVID website or webpage has a really nice graphic summarizing who had the statewide regulations on business and mask mandates, and then I'm blanking on the other one, businesses, mask mandates, and stay at home. And I looked at that, just trying to kind of see what they're doing, and what we see out there is in part because we don't have a unified approach from the federal government. So, and each state is kind of doing their own thing. And then within states, each counties are kind of doing their own things in certain states. So there's no uniformity to what's happening in our country. Mask mandates are widely in place across the country in several states. And then some states that it's mixed. So that would be, although they don't list us as mixed, but I would think Tennessee would be mixed because some places have mask mandates and some places don't. So there are probably about 25 or 35 states that have mask mandates in place right now. And then some of them that just have a variation of mask mandates out there. So that's kind of what's out there. Some places are still completely closed down. Some places have curfews in place, and some places don't have any of that in place. And I tried to compare it to, looking at what is their rate of new cases per 100,000 population, because you can't just look at rates or just raw numbers, because in a tiny state like North Dakota, compared to California is always going to have more cases because they just have more people. So if you break it down that way, you do see more mask mandates in those states that are kind of on a slower trajectory in increasing cases. I'll be honest, when I looked at the data, only one state appears to be stable, and that's Hawaii. They appear to have a stable rate of COVID. Everybody else is climbing. Some people are climbing, some states are climbing higher than others, but if you break it down, And in those states that have a slower rise in their cases per 100,000, there were more. You saw more You saw more mask mandates, and you also saw more mixing of closures and fewer totally open states. And then if you looked at the states with steeper climb, you didn't have as many mask mandates, and they were fully open. More of them were fully open for business and not having any restrictions. And those restrictions were everything from things were closed to curfews. And then if we go back and look at data from the White House report, where, with Tennessee being a red state, they've continued to recommend that, that Tennessee increase regulations. And one of the recommendations is, has been for a statewide mask mandate. We don't have that. We have a mask mandate here in Knox County, but they've also recommended reducing restaurant capacity and or closure of bars, and consideration of closure of gyms, which kind of goes along with Dr. O'Brien's data, where we see that's where people are going, and that's where potential exposures occur. And then I also looked at some other data just to kind of get my head around what could we do, what would make sense, what things might work. And I know I shared the or spoke of the Arizona data, of the Arizona Morbidity and Mortality Weekly Report. For some reason, that's hard for me to say. And if, Catherine, if you want to show that page. So this is from, they looked at in the state of Arizona from January 22nd to August 7th, and looked at their cases and mapped out the different things they'd put in place. And you can see back on May 15th, when the stay-at-home order was lifted, they did see a rise in their cases. And the cases continued to rise for quite some time. And they put some things in place. They put a mask mandate in place, and then they closed bars and gyms and other facilities. And then they did eventually start seeing a reduction. They also reduced dine-in capacity by 50%. And then on July 23rd, they extended those. If you go back and look at Arizona now, those restrictions have been lifted, and you do see that their cases are going back up. So, this demonstrates that putting things in place does work. And I know we struggle with that balance of the economy, social well-being, mental health well-being, and all the things that, closing things down can do. And if I think of just the purely public health approach to this, I think I said this last time, the pure public health approach is just to lock things down. But we know we can't do that forever, and we know that has detrimental effects on our economy, on people's mental health, on people's well-being, on families. We've spoken with our partners at Children's Hospital, and they certainly are seeing increases in visits for mental health in pediatrics. And that's everything from, mom and dad aren't working and we're stressed out about that, to we're just stressed out about COVID. And so we know these have large impacts. So I'm not suggesting that we close everything down, but I think we need to have a conversation about what could we do based on data. And then the one other piece of data that I looked at was another MMWR that was published, September 11th, 2020. And what it did is looked at people who had COVID symptoms and went and got tested. And so they took the people who were negative and the people that were positive. And so the negatives were their control group and the positives were the cases. And they went back and looked at what they had done in the 2 weeks prior to becoming sick. And what they found was most of those people, about 70% of the people who got sick were wearing masks. About 74% of the people who got COVID were wearing masks. 74% of those who did not get COVID were also wearing masks. But where it diverged was the fact that I have to find the number. Hold on a second. 63% of the folks who had COVID versus 44% of those who didn't have COVID reported having eaten at a restaurant or a bar 2 weeks prior to getting sick. So, you know, you can be compliant with wearing your mask all day long, but you definitely can't wear a mask when you're eating. And so if you're eating in a restaurant with folks who are outside your household, that's a risky exposure for all of us, especially now in Knox County. That's a risky exposure for us. So that's kind of some of the data that I've looked at in this short period of time. And another White House report recommendation is to limit crowd size, limit gathering size. And I tried to look it up because I didn't write it down. I thought I did. But that was another recommendation from the White House. I'm happy to answer questions, or if anybody else has looked at any other data that would be useful for us to talk about.
Dr. B, specifically on the behavioral health side, and year over year in 2020, we've seen a 44% increase in drug-related deaths. In the 55 and older age group, it's doubled. So behavioral health is a huge issue. Also, we're concerned that we see less reported cases of child abuse, but the issue is that is there really less cases, or are the cases just not being reported because the adults who the children would normally be in contact with, they're not in contact with. So in all these things, there's a lot of dynamics at work here.
Absolutely. I think, you know, everything from just being scared about getting COVID, being scared, you know, about your exposures and economic worries and the changes in our social interactions. It's impacting all of us. I mean, it's impacting all of our families, and that's where, you know, we have to try to balance as the Board of Health. You know, when we think about health and that broader definition of health, of, you know, that encompasses not just the fact that you don't have a disease, but your overall health, your social, emotional, and mental well-being, as well as your physical well-being. I think we have to think about all those things when we're making these decisions, and use the most, and I've said this before, use the most surgical approach we can that has some evidence behind it. The challenge with evidence right now is that this is new. We've been doing this for what, in the United States, we've been doing it for 10 months, maybe not even that long. And so, you know, think about how long it takes to develop the body of evidence that we use to decide how we're going to treat heart disease, or how we're going to treat diabetes, and how we're going to do the other things that we do. And I think we have to use what evidence we have and understand the rules of the virus don't change. COVID is a virus that's passed through respiratory droplets. Somebody said the other day, it's a social virus. It likes to be spread on social occasions. So how do we help our community decrease social interactions in a way that's reasonable? I guess that's what I would say. I think, you know, I said before, we're just at a place where the number of deaths we're seeing and the number of hospitalizations and the case increases are just really not acceptable. We're beyond concerning. We've averaged 2 deaths per day of people in Knox County for the past week, or close to it. And that shouldn't be acceptable to anybody on this board. And what can we as a board do about it?
I'll just bring up, you know, Nashville is implementing something which I don't know how we could do here locally, which is permitting every gathering of 8 people or greater. I was looking at their application process, and that's for any gathering. You're going to have people at your house for Thanksgiving. They will on there that they want you to get a permit. I don't think that would work here. I don't know how we could evaluate that. I don't know how the staff of the health department could do it, and that's what Metro Health is having to deal with. So we have to look at things that I don't think are reasonable and kind of take them off the table. But then we need to talk about other things that may be reasonable, like, do we change the capacity of indoor dining? Do we stop indoor dining for a defined period of time, a short period of time? Do we stop indoor bars? I think all those things are on the table, and based on this mobility data, we need to kind of look at where people are going. And then for a short period of time, we may have to implement something that kind of ratchets things down, and we watch it very closely. We have to watch the economy, but we also have to watch the spread of the virus. So this is where we got to do the balancing act, folks. So I think those things are on the table. We're not going to be like Kentucky with what they're doing. They're doing a major shutdown basically until I think it's December 13th. So that's their time period that they're using, Governor Beshear's. But I think if we look at something, we need to be looking at maybe a 2-week, 3-week cycle to look at, trying to find some specific things that we could work on that are reasonable and helpful.
So I had a follow up actually on the Kentucky piece, and Mayor Jacobs, this is just just something that they've done. I agree with Dr. O'Brien that we wouldn't model what we're doing over Kentucky, but part of what they did, and I think Dr. O'Brien characterized it well, is it's pretty far reaching. But then I think the governor announced the launch of a $40 million fund to assist restaurants and bars impacted by the closure of indoor dining. Entities that qualify will receive $10,000 to use for various costs. Businesses will be able to apply online. Now, I'm not suggesting that to be done locally or that there's the funds. I mean, this was a state.
Yeah. Yes.
Anyway, anything that could be done like that?
The state already has those programs, or had at least when the first shutdown went through. So yeah, Governor Lee had already moved in that direction.
But given where we are now, though, are those things still in place, or could they be in place again?
It could be, yes. Yeah. If now, of course, that would be across the state. So if we're talking about something that is done at a local level, that would become problematic to go to the state and say, hey, can you set aside millions of dollars for Knox County restaurants? That would be something that has to be done statewide.
And do you have a sense, I mean, based on just what you know, and you obviously know more than we know, whether anything at a statewide level would be anticipated?
I think some of that money is still available. Actually, I don't think that they were still soliciting applications last I heard. So they might make that re-available again. That's the best answer that I would have for that.
Okay. And then just an unrelated but related point is that, one thing that irrespective of what we decide that we can do, I think the other message to the community about this is, regardless of what we do, I think knowing the vaccine is on the horizon is just, everybody has their own risk tolerance, but it's about trying to minimize unnecessary risk. Because I don't know about you guys, but the number of people that I'm starting that are personal acquaintances of mine who have COVID, who actually have no idea how or where they got it, has increased. And so, for example, I had a Zoom meeting this week with someone who is 5 doors down from me, because if we're going to be together for an hour, and I do trust masks, but at the same time, that if you don't have to be, and this kind of gets into how people are celebrating Thanksgiving, if you don't have to be around, and then there's I get the isolation piece and people have to maintain that connection, but anything you can minimize, you should minimize. And that also gets back to that congregational dining piece, is that, we have absolutely tried, in our workplace, tried to minimize that in every way imaginably possible, because that is probably for those who are trying to kind of, just practice those 5 core actions. Congregational dining is a definitive risk.
And we certainly could do something like, putting back out kind of the 5 core actions plus, with some of those, some of those other things about, like guidance for employers, not carpooling. I know that's the environmentalists listening will cringe, but, definitely you're less than 6 feet apart, even if you're wearing a mask. If one of those people becomes a case, that person's quarantined. So as an employer, it becomes a staffing issue. And so not carpooling and limiting those face-to-face meetings. Here at the health department, we're trying to do the same thing because, we've had a couple of events where we're like, oh, and we hadn't thought about that. So maybe some of those, also some helpful hints for employers on how to safely do business, and maybe encouraging work from home again for a while, because that way people aren't gathering in the office and they're not having those lunches, and they're not sitting around the table with the people they know and they're familiar and they're comfortable with, and forgetting that they're not 6 feet apart or that they are taking off their mask even. So we could certainly put something out there like that, which I think would be helpful coming from this group. And I think, I don't know if we could get what's the name of, I can never remember the name of the group, the other group, the recovery group. I don't know if they would be willing to kind of sign on to something like that as well. That's one thing we could do. It's an idea. I think we might need to do something more restrictive than that, but I think that kind of putting that out there to kind of make it through the holidays. But I think we do need to take this data seriously and take the numbers seriously and consider what in our toolbox or what could we possibly do that might help reduce the case count climb.
I'm going to throw it out there to our other members to see if there's any other feedback. Some of us speak a lot more than others. So what else does everybody else think?
So Dr. O'Brien and board members, I had a short comment about the mental health side of this, because the endpoints that we've looked at have been basically more people maybe lapsing into opioid addiction or opioid overdoses or suicides, which are pretty drastic endpoints. And I had an opportunity to have a pretty extended discussion with one of the members of the pastoral team here at UT. And his comment was that it will be very interesting to look into 2021 at the divorce rate in 2020 and the amount of marital strife that has occurred this year. That's all under the radar. Unless your counselor says something about it, nobody really knows. But that's the same mental health issue, but at a much more widespread, but not as lethal a level.
I'll throw out one thing that goes with that is I sit on the prescription drug task force for the area, and we had the medical examiner give us the current data. We are way surpassing our deaths from overdoses and suicides at this point, and very concerning to us. And trying to work with our prescription drug task force with mental health experts to see what we can do to help, and looking for ways to intervene real time as best we can, potentially with people who are having crisis, trying to look at new ways to do that in conjunction with different agencies in the area, plus with maybe first responder agencies. So that's under discussion. We understand it's there, it's real, and it's serious.
I think that to tie that point, the mental health point and an economy point together, is that irrespective of what we decide to do, COVID is getting significant enough that it is going to change a lot of people's behavior. It may not change enough necessarily to impact the hospital census and all that, but there are going to be individual people who make decisions to do things that they would have not otherwise done, and that will have an economic impact. Just the strain of all this, of the increased cases, and the more acquaintances we have that have COVID, or a business that has a lot of people who are, it's not just the people I know, the majority of them who are out is not because they're a contact, it's because they have COVID right now. And so more businesses are going to be affected by that. And so one thing that that I want to make sure as we talk through any potential action is I think the point of which an action is symbolic is past us now. I mean, the idea would be that if there is an action, and as much as possible, I'm like, everybody, I want this to be in the hands of the community, but, we're at higher rates than we've ever been before. And so, the idea that you do something that really isn't going to curb that, we need to be thoughtful about it. Is it going to have the desired impact given where we are right now? But the society is going to feel the impact of COVID over the next 3 months, no matter what. Whether there's action here, whether there's not action here, I mean, that's upon us. It's just a matter of, it's the balance of all these issues, and can we mitigate that? And will the action have actually a favorable consequence?
So Dr. Shamiya and board members, along those lines, I kind of have a comment about the scientific aspect or the science behind any of the mitigation efforts. And it's getting a little better, but when we talk about following the science, that's not a monolithic entity. It's a very dirty entity in most cases that the public is just seeing as scientific thought and debate are going on. There's not one answer sometimes. And I've gotten some papers that I was looking at last night that I'll share with everybody from Cochrane and some from Cambridge Collaborative, which are the two of the world's best looks at evidence-based medicine, and their take on masking, their take on social distancing and such probably works. Doesn't work anywhere as well as we would like it to. The effects may be additive, but in discussing mitigation measures, there is information out there, again, from very reputable collaborative efforts about this. It's not, none of the things that we're talking about are a magic bullet, but they work in synergy with each other.
Yeah, this is Maria. I'd like to tag onto that and some of the ideas expressed earlier, which is, one, I think it's really important for all of us to continue to make the distinction between the rules of the virus, which is, it is a social virus, it is transmitted via respiratory, and any rules or mitigation efforts any community puts in place. Those are two different things. We put the rules in place in response to the rules of the virus. And what we know about things like masks, physical distancing, etc., is that it goes both ways. Yes, it's not a magic bullet, but we also know there's enough evidence. In fact, there's a new study that just came out of the NIH that mask wearing, mask regulations actually help decrease anxiety. So it's not the masks that are driving the mental health issues, because we have lots and lots of research over the years that show in a time of a natural disaster, mental health is really vulnerable. Mental health issues skyrocket. And that's what this pandemic is. This is a natural disaster. We are trying to mitigate as best we can by, again, that fine line between trying to keep people physically safe, keep our fellow citizens safe, and also preserving their, as best we can, their mental well-being. So I just want to be very clear that the message we send in what we discuss is that mitigation efforts are not what are driving people to depression. The pandemic, the virus, which is a natural disaster, is. Well, that's what I want to say about that. I mean, yesterday alone, nationally, we had over 2,000 people die. Nationally, that's one person. I did the math, about a person a minute, a little over a person a minute died yesterday nationally. And total in Tennessee, we have had, I think, about 4,900 some odd people die. So that's a little less than double when the Twin Towers fell, the number of people who died in the Twin Towers. And most of us, I'm sure, know exactly where we were when that happened. and that was devastating to us as a nation. And we came together. And, you know, if we can think just Tennessee is the Twin Towers doubled in slow motion. That didn't happen in a couple of hours, but slow motion, but that doesn't negate the impact on people's lives in terms of lives lost, communities changed forever. So I think our numbers are heartbreaking, and you know, I will not buy into some of the feedback we get from people of, you know, this is, you know, let nature take its course. Death is a part of living, you know, living, et cetera, et cetera. And I'd like to say that we have gotten a lot of feedback in the past 24 hours from our fellow citizens. And the majority of people, in fact, I kept a little tally. I don't know if you can see this. I kept a little tally, but out of the 100 and almost 150 emails we received in the 24 hours, it's 6-1. People actually are begging us to implement stricter mitigation efforts, to enforce what we have in place, the mask mandate, social distancing, et cetera. So our community realizes we are on the cusp of more heartbreak. And they want us to do something. And so that's why we're here. And I'd really like us to consider putting things back into place that we let sunset in terms of, you know, limiting social gathering size, thinking about changing the curfew to all places that sell alcohol. This is based on the science. It's not willy-nilly, again, arbitrary or capricious decision on our part. But I think those are things we need to talk about. What can we do to put things in place that are more than just a recommendation, but actually enforce what we know will keep people safer.
Thank you, Dr. Hurt. Any other discussion? We're somewhere between other regulations and maybe discussing options for further Board of Health action. We probably have kind of morphed into that if we want to continue discussing options, either in general or maybe some concrete discussion.
May I underscore what Dr. Hurt said about, and she didn't say it in these exact words, but the virus is the enemy and not additional measures or increased regulations. And I think to Dr. Shamiya, you mentioned not knowing exactly how successful additional mitigation efforts would be. To do nothing, I think we know would be pretty damaging. I think I would support putting additional restrictions in place if that's the direction that we're thinking about going. And I'm wondering if there's anything that can be done more quickly. I know we can't do anything tonight. And so I'm wondering what our options are for that. But I want it to be known that I would support additional regulations as well.
Yeah, so I'm willing to, if Mr. Sanders, if you're willing to work with me over the weekend, if the board wants some regulation ready for next Wednesday, we can work on putting that together if that's the desire of the board, and just need to know what that would be. So
I'm available, sure.
Thank you.
I'm going to just throw something out there. Wednesday may be too long to wait.
I agree.
Given how things are going, and that Wednesday is the biggest night out in this town in general. So having regulations that would be in place by Wednesday may be more beneficial than anything, because I'm worried that we'll have a super spreader event when everybody gets into town Wednesday night and they go to wherever place they want to go to. So we may have to have another emergency call meeting like on Monday to deal with this. and not wait till Wednesday. And I think we need to talk right now. What are we talking about? Are we talking about decreasing capacity in restaurants to 25%? Are we talking about closing indoor dining down, indoor bars and gyms down for a 2-3 week period, and leaving takeout and outdoor dining and other things maybe potentially available? We have to put everything on the table, and we need to kind of discuss them and figure out which ones are the least intrusive, but give us the most bang for the buck, and do it for as short a period of time as we can to be successful. We can always extend something. So if we said 2 weeks, we can extend it another week or whatever. But we need to really, I think, do something, and we need to be honest and talk about it in public with what we're thinking about, and then go back and put something, pen to paper.
So Dr. O'Brien, to that point, and I'm going to get Mr. Sanders involved in this discussion, my understanding in terms of setting meetings, maybe meetings that we have binding votes on, requires a public notice. And we needed a 48-hour public notice for this meeting. I would assume if you wanted to move even one day up, you would need a 48-hour notice. And I don't know whether we could have a voting action on that or not if we put it to Tuesday instead of Wednesday. As it stands now, on Wednesday, I think we should be able to vote, make measures and such, because that is a regularly scheduled meeting. Mr. Sanders, can you help me or help the board out with that?
Sure. There's no hard and fast rule of 48 hours. Has always been our rule of thumb for public notice, proper public notice. And right now, so that means you could right now schedule a meeting for as early as Sunday night. I'm not suggesting that you do it on Sunday night. I'm just saying that, anything, you can schedule a meeting out for Sunday night or Monday night or Tuesday night or whenever, anytime past that. 48 hours is good notice. And again, I've mentioned this before, I would like to be able to put the actual language of a resolution out at that same time. Having said that, there's no hard and fast requirement that it be out. As long as the item that you're going to discuss is on the agenda, you don't have to have the underlying language, but it is nice and we try to do that. So I would suspect that even if Dr. B and I worked on, and whoever else is interested, separately, obviously, to avoid open meetings issues, but even if we worked on this tomorrow, we could not get documents ready before tomorrow afternoon or evening. So you probably are looking at least Monday night, if you look at 48 hours past Saturday.
So Monday or Tuesday would be acceptable in terms of public notice and in terms of getting community TV or YouTube available. That's kind of a nuts and bolts issue, but that's part of it as well.
No.
Nuts and bolts are not my bailiwick.
Yeah.
See, community TV is not a requirement. It's something that we do as a courtesy to the public. We can make these available through YouTube and through the Knox County website. But I'm looking at our rules under called meetings, page 7 and 8. The 48-hour notice requirement may be waived in a declared state of emergency or in matters of great public importance where time is of the essence as determined by the chair of the board. So again, what Mr. Sanders said, the 48 hours is not a requirement. It obviously would take some time to put a regulation together once the board decides what it is they want to regulate. But certainly we could have a called meeting on Sunday or Monday. And it would be nice to, I think, if we're going to do something that impacts businesses, to give them as much time as possible to make changes.
And keep in mind also that you need a quorum to actually pass a resolution. So you better make sure that at least 6 of your members are available to meet on whatever day you pick.
Yes, thank you.
So, Dr. Buchanan, when we talk about what this might look like, and this kind of gets back to my other point, I mean, the rate of case growth that we have right now, and knowing how strained contact tracing is, and then the life cycle of the virus, you know, we already had a stay at home when we really didn't have much. And by the way, I'm not proposing a stay at home. That's not where I'm going with this. But to talk through this, you know, when we prevented a spike in the virus the first time here in East Tennessee with the stay at home. But, you know, given the rate that we have, you know, and granted, blunting this is still a good outcome, you know, but what I wouldn't want us to do is to do something that, you know, we're so conscious of balancing these issues is that we don't really accomplish much. That was my point about the time to do something that is purely symbolic. So we are doing something. At some level, that's treating ourselves. And I don't want us to do that. And so, you know, I would just want a sense from you that whatever we're doing, balancing all these issues was enough to accomplish something. Does that make sense?
Yes, it does. And I appreciate that. I mean, I think one, you know, we know that social gatherings are a place where exposure occurs. And so I think going back to limiting social gatherings is a place to start. I think that's something that we know can be impactful, and, you know, it just helps. I mean, reducing the number of people you get exposed to reduces your exposure and reduces your risk of getting COVID. So I think that would be a helpful one. Based on the data, I think something around restaurants would be useful as well. I'm not sure what that looks like. You know, the White House report recommends reducing restaurant capacity to, I just pulled it up and now I forgot. I think it said 50%.
25%.
Under 25.
25.
Okay, thanks. I mean, that's something else we could do. I think we could consider expanding our curfew or shortening the curfew. You know, going all the way back to restaurant closures with drive-through, drive-up, or curbside or delivery only. That's a pretty drastic measure, but we do know that it limits exposures. Again, when we look at cases of COVID versus people without COVID, eating at a restaurant is something the cases did more often than the non-cases. So, you know, I wish I could say this is the thing that's going to absolutely change the numbers, short of totally shutting down everything and going back to stay at home. There's no definite evidence for that. So I'd really appreciate the wisdom of the board to share your thoughts. We haven't heard from some of you.
Question.
This is Oh, go ahead, Marcy.
Do you know the restaurants, I guess, across Knoxville and Knox County, do you know if any are really limiting their current capacity?
The Tennessee pledge, I think, just says keep 6 feet of 6 feet of distance between the tables. I'm not really going out to restaurants, so I have not observed that. And I can ask my staff if they've observed it, but I'm not really going out to restaurants very much.
Yeah, me neither. But yeah, so I'm wondering if that, you know, ideally we don't want to completely go back to curbside only, because I think that certainly does hurt the businesses. But you know, if they're not limiting their capacity at all, reducing it down to 25% may be an option that could certainly be a compromise. I don't know if that would be enough to make a huge difference in our case numbers, though, as they keep climbing.
Dr. Buchanan, I have a question for you.
Yes, ma'am.
What do you think we could do to the gym participation? Can we reduce the number of people that go inside?
We can certainly, there have been regulations in the past limiting gym capacity, and I'm looking at Tennessee Pledge to see what it says currently. So currently what it says is limit facility occupancy to allow for appropriate distancing and limit congregation in locker rooms. In the past, we've limited gym capacity to a certain amount based on square footage, I believe. Or yeah, I'd have to go back and look, but there have been, those have been in place to limit gyms. So
Well, I've also had a lot of people call me about the yoga classes are really crowded. And, a lot of people have refused to go.
well,
Okay.
that's taking personal responsibility, not going to that crowded yoga class. I support that.
Dr. B, what have our contact tracing shown as far as restaurants and fitness facilities?
Well, and I'm going to let Charity speak to that because she has more direct knowledge of that restaurant. What contact tracing, what is it shown about?
Yes, this is Charity Menifee with Knox County Health Department. So we've been saying this a lot. We hear a lot of information from our cases that it's the social gatherings piece, the small social gatherings, groups amongst friends or coworkers, and that does occur at homes and offices, but it's also occurring of dinner parties at restaurants and gatherings in those situations and bars and that kind of thing. Do we have clusters associated to outbreaks from there? No, because it's typically linked more to those social relationship groups that are identified. The other point to make on this is with the level of community spread that we have, and I think Dr. Shamia hit this recently as well, exposures are everywhere, and so it's getting harder and harder to pinpoint because people have so many different high-risk exposures that they are mentioning. And so that just gets to be more challenging. And so then that's where having to look at, the evidence of where are people able to congregate with groups outside of their households, and what does that look like, and where is that most frequently happening? And we have heard for many cases of that, and working on getting more data to be able to collect that information and share it. But at this point, it's the social gatherings that are happening across the board, and restaurants are absolutely included in where those occur. Can we say this part? And then we did hear back from, this is Charity Menifee again. I texted Ronnie Neese, our Director of Environmental Health, who said that most of the restaurants are currently following the Tennessee Pledge and having the 6 feet between tables guidance. So, and again, I think, it's just to add some perspective there, it's 6 feet between tables is great, but it's when you have combined groups that aren't from the same households at the tables that is where the really most risky behavior is. It's not so much, and I think this is where, getting to your question, Mayor Jacobs, about identifying what contact tracing is saying. You're not seeing servers spread it to patrons and that type of thing. Or patrons spreading it to servers. Again, it's the interaction between the people, that social piece of the virus that is the highest risk while sitting, in a group together, wherever that is, at work or at the restaurant, at your home parties, those types of things.
So in thinking about that, if we were to limit party size, we've done that in the past. We had a limitation on party size, unless it's your immediate family. So we made an exception because we got feedback from somebody who had, like, with the party size limit was 6, and she had 8 people in her family, and she was like, we couldn't eat because we couldn't sit together. I get that. That makes sense. So we'd language it such that, outside your immediate family, you limit it, limit the party size. And that kind of takes care of, if they're already spreading tables out by 6 feet, then you're still eating within your household. and you're not eating with people that you don't normally hang out with and take your mask off. So that's another way to limit those exposures.
There was one email that we had that talked about somebody who their workplace was having planning a substantial size party, I believe. And honestly, that the idea was that they were saying it was okay because we hadn't given explicit guidance to the contrary. And of course, we did have a gathering size, and then it lapsed. And so, as much as we suggested and encouraged things, I think there is the element of that if it doesn't get codified in some way, that it's not truly a strong recommendation. And that, I mean, some people may be not feeling good about doing something, but they feel like they have no choice. And then there may be a situation where, from a public health perspective, if there's science behind it, they need a more firm recommendation. And so that gets a little more to the I guess it all intersects, but that gets back to the gathering size piece.
I think there are 2 points that I'd like to bring up. Number one is people will just go to the adjacent counties when it comes to restaurants and gatherings. Number two is I'm very uncomfortable with shutting down fitness facilities again. We should be encouraging good health and exercise. Certainly guidelines, and I think that they will follow those. But as far as impeding that business again, I think that does not help us when we're looking at overall health.
So, Mayor Jacobs, on that point about the adjacent counties, I did, I've made the point, I think we all sense this. I mean, this is not just a Knox County issue, clearly, at this point. But on the other hand, we can't affect the other counties. That's not within our purview, but yet there is a clearly accelerating pandemic. And so I guess I just don't want to use the fact that, that a contiguous county may not be wearing masks like Knox County is, or the fact that people can leave Knox County and go to a county. I've made it clear I want any action to be impactful. I'm very sensitive to all these issues, but on the other hand, this is a statewide issue, and the fact of the matter is that those counties are not influenced by what we can do here. So how do you reconcile those issues?
I mean, that's just the reality of it. They are under the Tennessee Pledge, so there is that. But as far as otherwise, that's just the reality of it. And I don't know how to reconcile that.
Well, to piggyback off of what Dr. Shmia said about how we can't really control what surrounding counties are doing, there are folks who, no matter what recommendations and regulations are put in place, there are folks that will choose not to follow. There are a lot that will, and that could be potentially quite helpful.
Yeah,
Agreed. We've gotten overwhelming feedback from the community that they want stricter regulations and they want enforcement. That word keeps coming up over and over again. It's not enough just to have a mask mandate. There needs to be enforcement. And to tag on to this idea of economic impact by any kind of mitigation efforts. I'm going to read here, our own Knoxville Chamber of Commerce. This is a quote: "Low consumer confidence is still contributing to slow economic recovery, especially as the number of COVID-19 cases continue to increase, along with hospitalizations and unfortunately death." So mitigation efforts to bring down those numbers of infections, hospitalizations, and deaths will increase consumer confidence. This is what we know. Nobody here is talking about shutting the whole community down. Handful of people in the community that are very concerned about that. That is not our intention. But I think, because we know there's not a magic bullet, but we know there are several ways to mitigate things. I'm suggesting a multi-pronged approach, not any one mandate or regulation, I should say regulation, but several. I think we need to enforce the mask mandate, or it needs to be enforced, excuse me, that's not under our purview, but it needs to be enforced. I regret that the social distancing and public gathering size was allowed to sunset. I think we need to bring that back, and I think we need to reduce the number to something like 8 or 10. We're not going to go into people's homes and police and make sure, they don't have one person more than 8 or 10 or whatever number we decide on, but it sends a message to people who need guidance. I also think we need to change the curfew. Again, as Dr. O'Brien has said, and others on the board have mentioned, we're not talking about forever, but we're talking about meeting the virus toe to toe and trying to keep it from getting the upper hand, which it's doing. And, we have to do our part. I agree with Ms. Roma, who said, we've got to do something. We cannot do nothing. And I said this earlier this summer, to do nothing is unconscionable. And that's even more true now.
Okay, so Dr. Hurd, I'm going to ask you to put that in a little more concrete language.
Oh my goodness.
Gathering size 8 to 10, then something about curfew. But I mean, let's if we're going to do that, let's get something down on pen and paper.
Okay.
Regulation.
Dr. Hurt, the things that you discussed are part of the White House briefing. So if we just, it's pretty clear cut. Dr. Hurt, everything that you said is right here in front of us. And so if we look at specifically limiting restaurant indoor capacity less than 25%, limiting bar hours, I guess it's still not as specific as Dr. Buchanan, what you're suggesting, but it's all right here to start as a starting point.
Agreed. So I propose that Dr. B, if you're willing to work with county legal, developing regulations that do each of those 3 things. We can talk about it. Obviously, we're going to talk about it as a group. Limiting restaurant capacity to 25%, reducing alcohol sales, setting the curfew back to 9 p.m. And we can hash out some of these details. Or Dr. Buchanan, you've done a wonderful job. You continue to do a wonderful job. I trust your judgment. I'm sure we all do. If you think it should be, 10 o'clock instead of 9 o'clock or whatever, those little details, I feel comfortable trusting you with sorting that out with Mr. Sanders. So what I say, 25%. Oh, and limiting gathering sizes to 8 or 10 or some number of people. And I would like to just tag on to, in terms of gyms and exercise, I totally agree. People need to have healthy outlets. Ms. Roma, I believe, do you teach phys ed? Is that right?
I teach health.
Health, right. So we know about that, but we need to think outside the box as a community. People can exercise outside of gyms. We can have, outdoor phys ed clubs, or I'm just talking off the top of my head, but we don't have to limit ourselves to thinking about doing things the way we've always done them. Just like Thanksgiving, we have to reimagine how we're going to have Thanksgiving with our families this year until we have enough measures in place, the vaccine, et cetera, people are vaccinated, where, next Thanksgiving can be different. And, again, as Dr. O'Brien emphasizes over and over again, we're not talking about forever. We're talking about buying our community some time, buying our healthcare system some time so that we're not overwhelmed and there aren't unnecessary deaths. So Dr. Buchanan, I threw those 3 proposals out clear enough?
Thank you.
I-
Thank you.
And I'm open to anyone else's help with the language of that.
Dr. Hurt, do we need to put something in there about masks?
Well, we already have our mask mandate. That's not going away.
Oh, okay.
So,
One thing, just, I don't know if you've heard some of the businesses, I can't remember which, if it was Walmart or Costco, you must now have a face covering, including a face shield, to come in. So if you have a medical reason for no mask or something touching you, you must have a face shield or you're not getting in the door. So that's coming from corporate, from a very large corporation. I think it's Costco. And so, we really need to strongly encourage, that sort of thing. We have, the city of Knoxville did pass their emergency ordinance Monday, where they're going to use civil penalties to enforce some of our regulations within the city. And the city has the lion's share of business that affects. I think it was about 5 to 1 or 6 to 1. So, we need to also strongly encourage our public. Come on, folks, things are getting bad. Please, for the love of everybody else here and yourself, hunker down and start doing all of these things. And when it comes to this coming weekend, with week and weekend, please really be careful. This virus is killing people. It's getting to the point now, somebody says, well, I haven't seen anybody that's had it or gotten sick. Well, I have, and I know somebody who's died. And it's real, and we've got to get really serious. So I think the curfew coming back 9 or 10, probably, I don't know, maybe 10, 8 people getting together, 25 in the restaurant, 25% in the restaurant, and do that for 2 to 3 weeks. And let's see what we've got. And, the city will help us. I've got to say, I'm challenging the county, and the county needs to help us on this. Let's just be honest. We need codes enforcement. We need the sheriff's office. We need others to help us. There are big gatherings going on in our community, and we know who they are, that are not being stopped, not being mitigated whatsoever, and those need to stop. And we need business owners who are doing that to get in line with their fellow business owners to help us, to help all of us. So I just implore you all out there that are listening, you don't want draconian measures, but we could do better if everybody has this enforced equally. And it may be something, I don't think I can get county commission to listen to do the same thing that the Knoxville City Council did, a civil penalty. Everybody was up in arms about criminal penalties and going to jail for 30 days. Well, the city's doing $50 fines, and maybe they will suspend somebody's beer permit. So there are ways to enforce, to encourage people. I don't want to see anybody get a fine or a suspension of their beer permit, but we've got to get really serious. And I think we're going to have to pass some new regulations here in the next 2 to 3 days.
Dr. Shamia, you mentioned many times that you want to make sure we pass something that's impactful. And I guess I would circle back to you to see if you feel like the current recommendations for clarity, are we saying move the curfew for alcohol sales, or are we saying that all restaurants, regardless if they sell alcohol, would close at 10 and maybe allow curbside to go after that?
I would vote for that.
Hey, folks, if I can intercede here, remember, this is not a voting meeting. You all can free to exchange ideas, and that's the idea behind the open meeting for a discussion. But you shouldn't be trying to finalize a resolution in this forum. You can bring suggestions to the meeting, and I will certainly work with Dr. Buchanan as well as any one of the others of you who want to work with me and propose your own separate resolutions. I will work with any of you and all of you to put something together for a voting meeting in the future, but you need to have the debate about the particulars of the resolutions at that meeting, not here. Because at some point we're going to run into open meetings issues or notice issues. So please just toss out ideas, send ideas to me, and then we'll put it on the agenda, and you can talk about the particulars of 8 o'clock versus 10 o'clock, or 12 people versus 20 people, or whatever, at the actual meeting where you vote. Okay, thank you.
Not to overwhelm your weekend's light reading, but I would encourage board members that have scientific information that supports or refutes or just discusses the mitigation efforts that we have discussed specifically here, to share those so that we have a little increase in our scientific background as we look at this. And I'll be happy to share what I have. And again, probably 1 or 2 cogent articles that I think I can come up with that are on the manner of evidence base behind each of those. And I've found a few of them last night. They're not hard to find. I'll be happy to share that with everyone.
Are we at a point to propose another meeting on Monday?
That would be up to the board and the logistics of the situation.
Hope you went mute, Dr. Gocher.
About that, we have Monday as a possibility. We have Tuesday as a possibility. We have Wednesday as a possibility. Mitigation efforts directed at Wednesday night. From a business standpoint, probably Monday would be a better night if those are actually followed through with. In terms of logistics of preparation of the board and all of our underpinnings that go with that, Tuesday might be a better night, and I might open that discussion to Mr. Sanders or to Dr. Buchanan and staff to see which of those days might work better.
I think that's a Dr. Buchanan issue. I'll make myself available whenever you need me.
Okay.
We can make Monday work. And if Mr. Sanders is okay with, we can get the agenda out to discuss. I think we have enough information to get an agenda out so people know what the topics are that are going to be discussed and voted on Monday. We could get that out tomorrow, and then have the actual regulation maybe ready Sunday for people to be able to see. Okay. If that's okay.
That's all right. And, it may be that we can work on the regulation fast enough to have it ready by tomorrow afternoon. So it just depends. I can be available, and I'll just be available electronically. I don't know if there's any reason for me to come to your office, but
no, I
can.
You'd be here by yourself. I'll be working from home. So yeah, you'd be here by yourself if you came to my office.
Don't think I have a key to the building, so.
Yeah.
What about Sunday night? I thought we discussed Sunday night.
Sunday night was mentioned, but I think in the interest of making sure that we dot our I's and cross our T's for the regulation, Monday would give us just a little more time to get that done. Because we don't just pull it out of our hat.
And if we pass something on Monday, we could then have it go in force at beginning of Wednesday at like 12:01 a.m. or something.
Yeah, I think time is of the utmost. I don't think we should wait till Tuesday. The sooner the better. That's reasonable with our schedules and our obligations.
Yeah, could everybody convene at 5 on Monday? Or can we have a quorum?
Yes.
Then?
Yes.
Okay.
So to Dr. Buchanan and the board, my answer is a qualified yes. I'm unfortunately on trauma call again. Last time I was, I probably work till 11 or 12 on Monday night. So with that proviso, I'll let you know as soon as things happen.
Thank you.
And it would probably be Monday morning when it would be sort of my drop dead time for telling you I can do it or I can't do it.
Okay.
And Dr. Buchanan, a while ago in the meeting, we discussed outside of the conversation and discussion specifically about regulations, the idea of maybe some additional education points, specific guidance for places of employment. I don't know if that ends up getting rolled into the same proposal or if it's different in some way and how formal it is. But I do think that's also, I know we've said that people have heard it so many times but we've shifted into a completely different, we need to, as much as possible, have the stay at home mentality, just as far as not taking risk. And I think people need to be reminded of what that was, even if all of that's not in specific regulatory language. And so if we can help educate as part of this, I think it'd be helpful.
Agree.
Dr.
Yeah.
Buchanan?
Yes, ma'am. You muted yourself, Diana.
All right.
Oh, you did it again. Can you unmute?
No, here.
There we go.
I see a lot of people that do not know how to wear a mask. And I don't know if we could get some education out about that, because in pharmacies, they'll walk up with it with their nose exposed. And I don't know what we need to do to educate people about that.
I don't either. We've done lots of things to educate, and we've got signs that, that we give out to businesses. And so I don't disagree that people need to wear their mask properly, but if you come up with a good way to educate them, let us know, because we've tried lots of things.
Dr. Buchanan, a quick anecdote to show you that sometimes, all politics and all of this is local. I was in our day surgery unit today, and there was somebody waiting for their loved one getting out, kind of a long beard and no mask, and very, kindly the nurse said, "You need to put your mask on," and the person immediately complied with it and put it on correctly. So sometimes it's just reminding somebody.
Sometimes it is. That's right. I would motion for adjournment.
Second.
Any discussion on that? If not, we are scheduled at this point for 5 o'clock on Monday afternoon, and hope to see everybody healthy and with us at that point, myself included. Hopefully I'll see everybody then. Thank you, and have a good night.